So, take a perfectly executed, like, textbook European rhinoplasty technique.
Okay.
Imagine a highly skilled surgeon performing that exact procedure on a patient in Dubai. The result. It might actually be a complete surgical failure.
Oh, absolutely. The swelling could be prolonged, the tip definition completely lost.
Right. And the patient is just entirely unhappy. But why? Because the textbook patient doesn't actually exist.
No, they don't.
So, welcome to today's. If you are watching this presentation with us, you'll see immediately that this isn't just a review of generic medical facts. We're looking at a highly visual slide deck called the Gulf Plastic Surgery Licensing Exams Master Course.
It's a massive visual gauntlet, really.
It is. We're basically decoding these intense diagrams and complication matrices that are designed to teach surgeons how to, adapt.
Yeah, it forces a complete shift in perspective because passing these licensing exams across the Gulf Cooperation Council, or the GCC, requires way more than just memorizing anatomy in a vacuum.
Right. The examiners want to see real-world application.
Exactly. They're testing whether a candidate understands how that anatomy behaves, how it heals, and how it ages in the highly diverse populations of the Middle East.
It's all about regionally adapted knowledge.
Spot on. That's the central theme running through every single slide we are going to look at today.
So let's start by looking at the opening matrix slide, right? The GCC licensing landscape overview.
Oh, the administrative complexity there is just daunting.
It's wild. For anyone trying to navigate this, you've got 8 distinct licensing authorities mapped out here, like the DHA in Dubai, the SCFHS in Saudi Arabia, the NHRA in Bahrain.
And they all use a standardized testing format.
Yeah, 100 to 150 single best answer multiple choice questions, taking about 2 to 3 hours.
Yeah.
But the scoring is entirely fragmented.
How so?
Well, Bahrain's NHRA requires a 60% to pass, but Saudi Arabia uses this scaled score of 500 out of 800.
Oh, wow.
Yeah, and the general baseline everywhere else just sort of hovers around 65%.
But notice the universal prerequisite flagged in the corner of that matrix, though.
It's a data flow thing.
Yeah, the data flow primary source verification. Regardless of the varying pass marks, every single authority demands this.
And it's not just, like, a simple background check, is it?
Not at all. The testing bodies actively hunt down every medical diploma, residency certificate, and prior license directly from the issuing institutions worldwide.
Wow, so they go right to the source.
Exactly, to prevent credential fraud. And that's followed by strict biometric checks on test day.
Man, they do not mess around.
Yeah.
And then if we move to the regional map slide, it visualizes the perioperative focus by country.
The shading is really interesting there.
It is. Dubai places a massive emphasis on aesthetic surgery, while Abu Dhabi's column focuses heavily on JCI Joint Commission International Quality Standards and hospital metrics.
Which really makes you think, you know?
Yeah. It's like getting a VIP all-access pass to 8 different elite clubs, but then you realize each club has a slightly different, incredibly strict dress code.
That is a perfect analogy.
So it makes me wonder, why is there such a push for a single, unified study resource? If every authority has their own specific flavors and hurdles, it seems counterintuitive.
Well, you have to consider the underlying constant beneath all that administrative red tape.
The patients.
Exactly. The specific testing algorithms change across borders, but the regional patient demographic remains the constant.
Ah, I see.
A unified preparation course like this synthesizes the baseline medical safety and core surgical principles expected across the entire Gulf.
So it guarantees a standard of care.
Right. Whether a candidate is operating in a clinic in Oman or a major trauma center in Kuwait, their foundational clinical judgment regarding this specific population is standardized.
So the biology dictates the standard, not the bureaucracy.
Beautifully put.
Well, to really grasp those clinical standards, we have to move past the administrative charts and look at the anatomical diagrams. And the visual shift here is striking.
Oh, definitely.
Pulling up the head, neck, and trunk slides, the first things that jump out are the bright neon warning labels.
They're impossible to miss.
Yeah, these aren't just basic anatomical markers. They are explicitly identifying exam danger zones.
Because those warning labels map out the most heavily tested nerves in facial surgery.
Like the red triangle on the side of the face.
Yes, that highlights the temporal branch of the facial nerve, and the call-out box notes its precise location. 1.5 centimeters lateral to the brow.
And there's another major warning below that, right?
Right, for the marginal mandibular branch. Injuring either of these during a facelift results in devastating facial paralysis.
Oh, wow.
Yeah, which obviously makes them extremely high-priority targets for exam questions.
Makes sense. And layered right over those danger zones is the SMAS, the superficial musculoeponeurotic system.
Such a crucial layer.
Yeah, the text on the slide indicates that understanding the SMAS and its retaining ligaments is basically the absolute non-negotiable foundation for facial aging and lifting procedures.
But the presentation doesn't linger on the face for too long?
No. Panning over to the trunk and breast anatomy diagram, the focus zeroes right in on the rectus abdominis muscle in the abdomen.
Right, and the visual highlights the segmental neurovascular anatomy of the abdomen because it's the primary donor site for major reconstructive procedures.
The flaps, right.
Exactly. Specifically, the slides mention the transverse rectus abdominis myocutaneous flap and the DIEP flap.
Which is the deep inferior epigastric perforator flap.
Yeah, you got it. Both are absolutely crucial for breast reconstruction.
Okay, and here is where the presentation introduces its most valuable concept, I think. Scattered throughout these complex anatomy slides are dedicated call-out boxes labeled Gulf Practice Pearls.
Those are my favorite part of the whole deck.
They're so helpful. They seem to be the bridge between what you read in a Western textbook and what you actually experience in a Middle Eastern clinic.
Because the pearls are the interpretive lens for the exam. Take the lower extremity reconstruction slide, for instance. It discusses utilizing perforator flaps like the ALT or anterolateral thigh flap. A perforator is just a tiny blood vessel that pierces through the muscle to supply the skin above it.
Right, right.
But the Gulf Pearl specifically notes that the anatomical availability and reliability of these perforators actually vary within the diverse genetics of Gulf populations compared to Western cohorts.
Wow, so you can't just assume the anatomy will be exactly what the textbook says.
Exactly.
Which brings us back to the rhinoplasty example we started with.
Right.
The rhinoplasty slide features a dedicated pearl regarding regional skin types.
This is such a highly tested area.
It notes that the thicker skin, typical of Middle Eastern populations, physically limits the degree of tip definition a surgeon can achieve.
Right?
So wait, a surgeon can't just use the exact same technique they learned in Europe or the US.
Not if they want a good result. If a candidate is sitting for this exam, they are going to be tested on their ability to adapt their technique.
Because the textbook angles don't apply universally.
Exactly. The textbook nasofrontal angle of 115 to 130 degrees is just a starting point. The examiners construct questions to see if a candidate will blindly apply a European standard to a Middle Eastern patient.
And if they do?
Failing to account for thicker skin leads to prolonged postoperative edema, loss of structural support, and ultimately a compromised airway or just a poor aesthetic outcome.
Yikes. So the boards really demand flexibility based on the patient sitting in front of you.
Without a doubt.
Well, if genetic variations alter surgical angles and flap availability, it makes sense that they also fundamentally alter how a patient heals.
Naturally.
Moving to the next module on the screen, the presentation dives into the microscopic level. We are looking at a dense chart titled Wound Healing and Growth Factors.
It's a lot of biochem here.
Yeah, it visualizes the 4 sequential phases of healing: hemostasis, inflammatory, proliferative, and remodeling.
And the exam heavily targets the proliferative phase, specifically the chemical messengers driving it.
The growth factors.
Right. The slide flags several of them. The derived growth factor is responsible for fibroblast chemotaxis.
Basically calling the cells that build tissue to the site of the wound.
Exactly. Then you have VEGF, vascular endothelial growth factor, and TGF-beta, transforming growth factor beta.
You know, visualizing these factors as a biological construction crew makes this much easier to digest.
I like that analogy.
Yeah, think of VEGF as the plumber. Its job is angiogenesis, laying down the microscopic blood vessels to supply the site.
Nice.
And TGF-beta is the concrete worker, synthesizing the collagen to build the actual structural foundation of the scar.
That's a great way to remember it. But the clinical photographs on the following slide show what happens when that construction crew goes rogue.
Right, an overactive healing response.
Exactly, which creates pathological scars. They're broken down into 2 distinct categories on the matrix: hypertrophic scars and keloids.
Let's talk about hypertrophic first.
Okay, so hypertrophic scars are raised and thick, but they respect the boundaries of the original incision. Biologically, they contain a high ratio of type 3 to type I collagen.
Got it. But keloids, on the other hand, are visually distinct in these photos. They spill over, extending way beyond the original wound, and they rarely regress over time.
Very difficult to manage.
And their composition is flipped, right? A high ratio of type Y to type 3 collagen.
Yes.
It's essentially the TGF-beta concrete workers refusing to stop pouring long after the job is done.
Exactly. They just keep pouring.
And the Gulf practice turtle box here is impossible to miss. It points out that the massive expatriate populations in the Gulf, particularly those of African and Asian descent, carry a significantly higher genetic predisposition to keloid formation.
And this demographic reality dictates a completely different surgical approach, which is why the treatment algorithm for abnormal scars flowchart is so heavily emphasized here.
Yeah, because the instinct of an untrained surgeon might be to simply, cut a massive keloid out.
Right, but the flowchart explicitly forbids this as a first step.
Because cutting it out just signals the construction crew to pour even more concrete, right?
Exactly, resulting in a keloid that comes back twice as large.
Oh, man. So what do you do?
The flowchart visualizes a strict doctrine of restraint. First-line therapy is purely conservative. Silicone gel sheets and pressure garments applied for 6 to 12 months.
That requires a lot of patience.
It does. And if that fails, the pathway moves to second-line therapies. Intralesional steroids, primarily triamcinolone.
Triamcinolone, okay.
Yeah, to use your metaphor, injecting triamcinolone acts like a foreman arriving on site and forcefully shutting down the concrete mixers.
I love that.
It suppresses the inflammatory mediators and degrades the excess collagen.
So surgery is really a last resort.
Absolutely. Only when conservative and medical management completely fail does the flowchart lead to surgical excision. And even then, it mandates immediate adjuvant therapy, like localized radiation to prevent recurrence.
Wow. Understanding that cellular-level behavior is critical, especially when the cells mutate entirely.
Which brings us to skin cancer.
Right. The skin cancer comparison chart next to the scar matrix presents a stark visual contrast. You have basal cell carcinoma, the most common, presenting often as a pearly nodule with low metastatic potential.
And on the other side is squamous cell carcinoma, carrying a much higher risk of spreading.
Yeah, and the visual call-out under squamous cell carcinoma brings in a highly testable, high-stakes concept, Marjolin's ulcer.
A classic exam question.
It's an incredibly aggressive form of squamous cell cancer that doesn't arise from sun exposure, but rather from chronic, non-healing wounds or old burn scars.
Exactly. And next to that, the melanoma staging diagram visualizes Breslow thickness.
Measuring the absolute depth of the tumor in millimeters, right?
Yes, that is the single most critical prognostic factor for survival. They will definitely test on that.
Okay, so from failing to heal to cellular mutation, the presentation logically bridges us to the surgeon's ultimate toolkit for fixing these deficits.
The reconstructive toolkit.
Right. The module is titled Reconstructive Principles, and the central graphic is a literal ladder, the reconstructive ladder.
Such a fundamental concept in plastic surgery.
It shows a stepped progression. Starts at the very bottom with secondary intention, which is simply allowing a wound to heal naturally over time.
And the rungs step up in complexity from there.
Walk us through them.
Okay, so primary closure is suturing the wound edges together. Then skin grafts, transferring just the skin layers. Local flaps, moving adjacent tissue while keeping its blood supply intact.
Getting more complex.
Right. Then regional flaps, bringing in tissue from further away. And finally, at the very top, free flaps.
Which involves completely detaching tissue, moving it to the defect, and meticulously reattaching the tiny blood vessels under a microscope.
Precisely.
Looking at this progression, the instinct in modern medicine is usually, newer and more complex is better. So it's tempting to assume free flaps are the ultimate gold standard.
A lot of people think that.
But analyzing the way this visual is structured, with heavy bolded text at the bottom, it seems the latter is actually a visual representation of restraint, not ambition.
That deduction is spot on, and it is a trap many candidates fall into on the exam.
Really?
Oh yeah. The foundational principle tested here is utilizing the lowest rung on the ladder that effectively, functionally, and aesthetically solves the patient's deficit.
So don't do a free flap if you don't have to.
Exactly. Exposing a patient to the lengthy anesthesia and vascular risks of a complex free flap when a simple, reliable local rotation flap would suffice is considered poor clinical judgment.
Right.
The boards will present complex wound scenarios and test your ability to know exactly when to stop climbing that ladder.
Choose the simplest tool that provides the optimal result.
Always.
The application of these reconstructive principles is further detailed in the pediatric and trauma diagrams. There's a specific slide mapping out cleft lip and palate repairs.
Ah, the cleft repairs.
Yeah.
Very specific timelines there.
Yeah, the cleft lip section has a giant box around the rule of tens. Surgery is timed for when the infant is 10 weeks old, weighs 10 pounds, and has a hemoglobin level of 10.
And the timing is just as rigid for the palate. The diagram notes cleft palate repair is targeted specifically between 9 and 12 months of age.
Is there a specific reason for that window?
The physiological reason is straightforward, yeah. Repairing the palate within this narrow window is critical to allow for normal speech development before the child begins forming complex articulations.
That makes total sense. Now, the trauma slides are equally uncompromising, particularly the intricate diagram of the hand.
Hand anatomy is a beast.
It visualizes the flexor tendon pulley system, explicitly pointing out the A1 through A5 annular pulleys. The text emphasizes that preserving these specific pulleys is mandatory to prevent bowstringing,
Right, where the tendon pulls away from the bone during flexion.
completely destroying the mechanical advantage and function of the finger.
Exactly. And hand reconstruction often coincides with burn management on these exams.
I saw that slide.
Yeah. The burn slide categorizes thermal injuries into 4 depths, but the most vital piece of data is tucked into the pharmacology table next to it.
The local anesthetics.
Yes.
There is a thick, black warning box around the absolute maximum dose for lidocaine when mixed with epinephrine. It is strictly capped at 7 milligrams per kilogram of the patient's body weight.
Very important number to memorize.
And the bold text below it identifies the treatment for systemic lidocaine toxicity. Intralipid emulsion, 20%.
The mechanism behind that treatment is brilliant, by the way.
How does it work?
Well, if a surgeon miscalculates and injects a toxic dose of lidocaine, it attacks the central nervous system and the heart, leading to fatal arrhythmias.
Terrifying.
Very. But administering intralipid emulsion intravenously introduces a massive amount of lipid droplets into the bloodstream.
Okay.
These droplets act like a circulating molecular sponge. They draw the lipid-soluble lidocaine away from the heart muscle and trap it until it can be safely cleared.
That is fascinating. It's literally a sponge.
Basically, yeah.
Well, this strict margin of error in trauma pharmacology highlights a much larger theme as we shift to the final section of the master course.
The aesthetics section.
Right. When the presentation moves from reconstructive principles to aesthetic body contouring, the baseline dramatically changes.
He does.
You're no longer trying to restore a deficit or save a limb. You're operating on a perfectly healthy patient. And because of that, looking at these final slides, the tolerance for severe complications drops to absolute zero.
The visual tone of the presentation becomes deliberately alarming here.
It really does.
The educational diagrams are replaced with urgent complication matrices and fatal risk warnings. Aesthetic surgery is an elective pursuit of perfection, and the licensing authorities ruthlessly test a candidate's grasp of safety boundaries.
Let's look at the breast implant comparison slide. It breaks down saline, silicone gel, and form-stable or gummy bear implants.
Right.
But dominating the bottom half of the screen is a massive section on BIA-ALCL.
Breast implant-associated anaplastic large cell lymphoma.
Yeah, that's a mouthful.
The mechanism of this disease is critical for the boards. It is not a cancer of the actual breast tissue. It is a lymphoma that develops within the scar tissue capsule that the body naturally forms around the implant.
And the slide clearly links this pathology primarily to implants with a textured surface rather than smooth ones.
Exactly, and the presentation highlights exactly how this presents clinically. A late seroma.
So a patient suddenly developing a massive accumulation of fluid around the breast more than a year after their original surgery.
Yes, and the diagnostic key, circled in red on the slide, is that the fluid must be sent for CD30 plus cytology to confirm the lymphoma.
Good to know. And the safety limits are mathematically rigid on the liposuction slide as well.
Extremely rigid.
It visualizes the Tumescent technique, where a surgeon infiltrates a specialized fluid mixture to numb the area and constrict blood vessels before suctioning the fat.
The ratio of fluid infiltrated to fat removed is usually 2 or 3 to 1.
Right, but the board-tested limits are the total extraction volumes, right?
Yes. A strict maximum of 5 liters for an outpatient setting and up to 10 liters only if the patient is monitored in an inpatient facility.
Wow. And pushing past those volume limits triggers massive, dangerous fluid shifts in the body's compartments.
Exactly, compounding the risk of lidocaine toxicity we just discussed.
It's all connected. But I have to say, the most jarring warning in the entire slide deck is on the gluteal augmentation, or BBL slide.
Oh, the fatal fat embolism risk.
Yeah. There is a glaring red box that simply reads, fatal fat embolism risk.
This is perhaps the most highly scrutinized aesthetic procedure globally right now.
I believe it.
The slide mandates that any fat transferred to the gluteal region must remain exclusively in the subcutaneous plane.
Meaning the layer of fat just beneath the skin.
Exactly.
The text explicitly forbids injecting fat deeper into the intramuscular plane.
Because the underlying anatomy explains why. The gluteal muscle houses a massive, intricate network of deep, large veins.
Oh, I see where this is going.
Yeah, if a surgical cannula accidentally slips into the muscle layer and tears one of those deep veins while injecting fat under high pressure, that fat doesn't just sit there.
It enters a wide-open superhighway directly into the central bloodstream,
Traveling straight to the heart and lungs, causing a catastrophic and often fatal pulmonary embolism.
This is terrifying.
It is. The mechanical movement of a cannula is easy to learn. What defines a master surgeon and what the GCC authorities are testing for is the deep anatomical respect required to avoid that venous network entirely.
It's knowing where not to go.
Exactly. And it also comes down to rigorous patient selection, which is heavily featured on the final post-bariatric and abdominoplasty slide.
Right. You can't just operate on a patient the moment they hit their goal weight after a gastric bypass.
No, the timeline on the slide dictates they must maintain a stable weight for 6 full months before any body contouring can begin.
And while the matrix notes that a seroma, simple fluid collection, is the most common complication of an abdominoplasty, happening up to 25% of the time, the critical event examiners want you hunting for is a DVT or PE.
Deep vein thrombosis or pulmonary embolism. Because achieving an incredible aesthetic result means nothing if the patient suffers a preventable thromboembolic event.
Absolutely.
Identifying the red flags, understanding the underlying venous anatomy, and knowing when to refuse surgery altogether is what earns a candidate their license to practice.
Stepping back from the projector screen, the sheer cognitive load required to master this material is just astounding.
It's immense.
We've navigated the fragmented administrative matrix of 8 different GCC authorities. We mapped out the critical facial danger zones and parsed the mechanics of perforator flaps.
We examined the cellular architecture of wound healing, visualizing how growth factors build tissue.
And why a genetic predisposition to keloids in the diverse Gulf populations requires, a forester's approach to steroid management rather than an immediate scalpel.
We analyzed the reconstructive ladder, learning that true surgical wisdom is knowing when to stay on the lowest rung.
Right. And we concluded in the high-stakes realm of aesthetic contouring, decoding the mechanisms behind BIA-ALCL, safe liposuction volumes, and the deadly anatomical risks of gluteal fat grafting.
But the most resonant takeaway from this entire visual masterclass for me is the philosophy behind the Gulf practice pearls.
They really tie it all together.
They do. This presentation doesn't just recite global standards, it actively adapts them. It demands that surgeons adjust their textbook angles for thicker skin, anticipate varying perforator blood vessels, and tailor their scar management to specific regional genetics.
It proves that applying a rigid, one-size-fits-all medical doctrine is a recipe for surgical failure.
Which leaves us with a pretty compelling question about the future of global medicine.
What's that?
Well, as human populations continue to migrate, blend, and mix at unprecedented rates, the idea of a standard textbook demographic is basically vanishing.
Oh, that's true.
So, will medical licensing boards worldwide eventually be forced to abandon generic testing? Will every authority, from North America to Europe to Asia, eventually have to adopt this highly localized, culturally and genetically tailored approach to surgical education just to guarantee patient safety?
Man, if the demographics are evolving, the textbooks have to evolve with them. That is a lot to think about.
It really is.
Well, thank you for taking a seat in the lecture hall with us today.